Welcome to our Brain Matters webinar. Tonight, our topic is New Insights on Cognitive Training and Dementia Risk Reduction, a 20-year follow-up of the ACTIVE study. This is a landmark study. It has been in the news quite a bit lately, owing to its very promising findings. Data from Data from the ACTIVE study suggests that a very specific type of cognitive speed training may lower someone's likelihood of developing dementia up to 20 years later. Dr. Marilyn Albert, a prior Brain Matters guest and the director of the Johns Hopkins Alzheimer's Disease Research Center, was quoted as describing the results as remarkable because it suggests that a fairly modest non-pharmacological intervention can have long-term effects. My name is Tony Tiano. I will be your host for this webinar. I work with the Johns Hopkins Alzheimer's Disease Research Center. Also on the webinar team is my colleague, Dr. Corinne Pettigrew, who will monitor the chat box during the webinar as well as the Q&A box. We also have with us Mrs. JoAnn Scipio. I would like to briefly pause to mention that Mrs. Scipio recently received this year's Outreach Leadership Award from the Memory and Aging Community Advisory Board in recognition of her leadership in advancing community health through sustained volunteerism, coalition building, and program development. Congratulations to you, Mrs. Scipio. Mrs. Scipio will MC today's event and kick off our audience Q&A period. Here's a quick overview of our agenda. As I just mentioned, there will be a Q&A period, so you may want to grab a pencil and paper and jot down questions as they come to you during Dr. Rebok's presentation, or you may drop them in the Zoom Q&A box as we go along. At this point, we would like to ask how you heard about the webinar. And Corinne is going to launch a poll. You can see there are several options for you to choose from. Please pick one, and if you're unsure, just click unsure, but if you know it's not one of the above, please tell us in the chat where you did hear about this. It could have been from a newsletter, it could have been on LinkedIn, it could have been from any other number of sources. So let us know how you heard about it. We're interested to make sure we keep in touch with you and let you know it's coming up next. Is everyone done with the poll, Corinne?
Yep, I'll give it 5 more seconds.
Okay, sounds good.
All right, all done.
Great, thank you. So now I would like to turn the floor over to the delightful Mrs. JoAnn Scipio.
Thank you, Tony. Good evening, everyone. We're honored to have Dr. George Rebok with us tonight. Dr. Rebok is Professor Emeritus in the Department of Mental Health at the Johns Hopkins Bloomberg School of Public Health. His research focuses on cognitive aging, preventive science, and public mental health. Dr. Rebok serves as a senior advisor for the Johns Hopkins Alzheimer's Disease Research Center for Minority Aging Research. And he was the site principal investigator at Johns Hopkins at the NIA-funded ACTIVE study that we will hear about tonight. Please join me in welcoming Dr. Rebok to our Brain Matters webinar.
Thank you very much, JoAnn, for the nice introduction. I'm very pleased to be here tonight. Let me start by thanking Corinne and Tony and JoAnn for inviting me to give this presentation, and for all of you to taking time to join us tonight for this webinar. Okay, well, I'm very excited to be here tonight, as Tony mentioned, talking about the 20-year follow-up of the active study tonight. This is a study that's been in the news quite a bit lately on CNN and NPR and in the Johns Hopkins magazine and several newspapers around the country. And we have been very excited about the media attention that is received, and I in particular feel fortunate to have been involved in this study for many, many years. Let me begin by saying that I have no disclosures, but I would like to acknowledge the generous funding I've received in support of the work that I'm going to be talking about this evening from the National Institute on Aging. Let's start with looking at the takeaways from the presentation tonight. Tony already mentioned about the sort of the headline from the 20-year outcome paper that came out about 4 months ago. And the main finding from that paper that was boosted speed training was linked to lower dementia risk 20 years later, which was really a remarkable finding because it was a fairly modest dose of intervention. Speed training without any of the booster sessions was not linked to lower dementia risk at the 20-year follow-up. So booster, this extra refresher training, was very important in terms of the outcomes. Neither of the other two interventions that we administered in active, neither the memory training nor the reasoning training with or without booster sessions had significant effects for lowering dementia risk. This was somewhat surprising. I know people in the media raised this as a question, and it's a question we can come back to later on in the presentation. But it's also something that I think where we need more translational research to understand why these two different interventions, memory and reasoning, didn't confer the cognitive protection 20 years later, whereas the boosted speed training did. Finally, there was no significant effect of age at training on dementia risk over 20 years of follow-up in any of the three intervention conditions, speed, memory, or reasoning. There was an interesting statistically trending effect, at least in the memory condition, for those who trained at a younger age, from 65 to 69, showing more protection against developing dementia over time, but it fell short of significance. So there were no significant effects in terms of how old you were when you received this training. I wanted to bring to your attention this report from the National Academy of Sciences. I think many of you are already familiar with this report. This was a report that was commissioned by the National Institute on Aging in collaboration with the National Academy of Sciences. And what they did was to do a extensive survey of the existing literature to see if there were interventions that had evidence behind them for preventing cognitive decline and lowering dementia risk. And based on this very extensive review of the literature, they identified three classes of intervention listed here: cognitive training, blood pressure management, particularly in middle age, and increasing physical activity. That those three classes seem to confer a benefit. And cognitive training, which is what we're going to be talking about tonight, there was moderate strength evidence for cognitive training based largely on the active trial, and that's the trial we're going to be discussing tonight. Now, this review didn't address the long-term benefits of cognitive training, and that's something that I think is new and is what we're going to be talking about today after, the 2 decades that have lapsed after the initial training. That was not part of this review, but cognitive training did emerge as one of the beneficial classes of intervention from this report. Before we get to the active trial and the results, I think it's important to address the question, what is cognitive training? And the way I'm using it here, it's guided practice on a set of tasks that are related to different cognitive functions like memory, attention, or other brain functions. It generally uses repetitive exercises, either for a single cognitive ability like memory or speed, or multiple abilities where you train two or more abilities at the same time. It can be what we call top down, so that you train people or teach people strategies for, let's say, memorizing material that you want to remember, or bottom up, more process based. And that's the speed-based training that we're going to be talking about is more in that category, more process-based. It can be compensatory, sort of developing workarounds for declines that you may be experiencing, or it can restore lost function. It may be computer assisted. It may be delivered via an app, or it may be delivered in person, either in in one-on-one sessions or in small groups, or even sometimes in large groups. Cognitive training is based loosely, I say, on the idea of neuroplasticity. Say loosely because a lot of the cognitive training programs sort of appeal to this notion of neuroplasticity to give their training programs sort of a scientific basis. A lot of times the scientific basis isn't very well worked out. But that's kind of the idea underlying cognitive training. It's not just puzzles or brain games. It's not just doing a crossword puzzle, or it's not doing some kind of mind game. It's sort of a structured series of different exercises that are designed to improve cognition. So why is it important, particularly in later adulthood? Well, we know that the 65 plus population is growing rapidly. By 2030, 20% of the US population, 72 million, will be over the age of 65. And by 2030, all of the baby boomers will have reached the age of 65. We also know from different surveys, including this one listed here from Harvard School of Public Health, that dementia is a feared aspect of growing old. In this survey, it was second only to cancer as the most feared aspect of getting older. Drug trial results to date have been rather disappointing. So there's more interest in more non-pharmacological kinds of interventions, and as well as other kinds of pharmacological interventions. We also know that cognitive impairment heavily impacts the aging population. 1 in 4 older adults has some kind of impairment without dementia. And the estimates are that about 7 million people in the US have Alzheimer's disease, and that's probably an underestimate. And we also know that there are well-known established disparities in terms of the incidence of dementia. African Americans and Hispanics have higher rates of Alzheimer's disease, two times and 1.5 times respectively, compared to the white population. This is a survey that the AARP conducted a few years ago with a national sample, asking about willingness to engage in brain training. If you wanted to a specific area related to cognitive ability, how willing would you be to participate in cognitive training? And the main result here was that a high percentage of older adults said that adults, actually this is middle-aged and older adults, said they were willing to participate in cognitive training. Slightly more women than men, slightly more younger adults than the older old adults, and more of the working adults said that they would be willing to engage in cognitive training. But overall, more than 80% of people reported being willing to engage in cognitive training. So there is a real interest out there. Whether that translates in actually doing it is another story. So what I wanted to do is to talk about the evidence from this active trial that we've mentioned. ACTIVE is an acronym. It stands for Advanced Cognitive Training for Independent and Vital Elderly. And it was a trial that was co-funded by the National Institute on Aging and the National Institute of Nursing Research. And it involved over 2,800 adults 65 plus that were recruited from 6 sites around the country. They're listed here: Johns Hopkins, Penn State, Indiana, University School of Medicine, Hebrew Senior Life, which is part of Harvard, Wayne State, and University of Alabama, Birmingham. I wanted to acknowledge the active steering committee and the wonderful colleagues that I've had the good fortune of working with for so many years. These are the principal investigators at each of the participating sites. I want to also acknowledge the co-funders again, and also the New England Research Institute's Coordinating Center, which organized and managed the different logistics of carrying out this clinical trial. The goals of the active study are listed here in the next slide. It was to conduct a large-scale efficacy trial of cognitive training. There were 3 distinct cognitive training programs, so the participants only got one of these 3 programs: either memory training, which was classroom-based, where we taught mnemonic or memory skills; a reasoning training, which was also classroom-based, where we trained logical thinking skills; and speed training that occurred also in a classroom setting, but that involved working at a computer, an adaptive computerized training of visual speed and attention. Everybody in the study received objective measures, standardized measures of cognitive performance, and functional measures of everyday activities like being able to manage your medication or being able to manage your finances. We also aim to evaluate the importance of ongoing booster training. So active, unlike most other cognitive training studies, involve multiple booster sessions or refresher sessions. And we wanted to measure the persistence of benefits after the completion of training to see how long these effects would last after the training. So here you see the 3 active cognitive training conditions. Memory focused on what we call verbal episodic memory. So we taught memory strategies for remembering word lists and main ideas in a story. For reasoning training, we focused on the ability to solve problems that follow a serial pattern. So participants practiced strategies on abstract thinking tasks, like a letter series task, where you had to decide what letter came next in the series, like AAB, BBC, CC, what's next. We also had more real-life types of examples. Here you see a hypothetical medication schedule where a patient is taking multiple medications at different times of the day and night. And so participants had to recognize the pattern in those medications and figure out that pattern. And then we have speed training, where it involved visual search skills and the ability to identify and locate visual information, particularly under divided attention conditions. So where you were paying attention to a central target on a computer screen, and then there were distractors that were introduced in the periphery of the screen. And you had to maintain your focus on the central target, but also try to figure out what's going on at the periphery of the screen. And then there was a no contact control group. They didn't receive any of the interventions or training, but they did receive all the assessments that the other 3 training groups received. Here you see the study participant flow in the active study. Participants went through a multiple stage screening and assessment process, and then they were randomized into one of the 4 treatment conditions that I just described. After the treatment, there was an immediate post-training assessment, and then 1-year, 2-year, 3-year, 5-year, and 10-year assessments. The booster training that I mentioned was given 11 months after the initial training, and then again 35 months after the initial training. So there were 2 booster sessions. And then we had a 20-year assessment where we did not actually go back into the field and test people in person, but we linked the data that we had collected through 10 years to large secondary data sources like Medicare records and driving records and credit histories. So here you see the active study hypotheses. We hypothesized that each of the training programs would show improvements on the related proximal measures, but not show transfer to other measures. So for example, if we train people to improve their speed of processing, that would improve speed, but it wouldn't necessarily make their memories better or their reasoning skills better. So each of the training was supposed to be very target specific. We also posited that the training programs would show generalization to functional measures. So we had measures of instrumental activities of daily living, IADLs, where people reported how difficult it was to carry out everyday activities like managing their medications, preparing meals, going shopping, things like that, driving. And then timed instrumental activities of daily living, where you did a lot of these activities under time conditions. So search the ingredients of on a can, what ingredients are in this food, or try to search for some groceries on a shelf and how quickly you can do that. And then we thought that the training programs would also show effects on additional measures like health-related quality of life, depression, automobile driving, and safety and mobility. Here you see the active 10-year results. We had reported earlier more short-term results. This was the 10-year results, and each of the cognitive training programs worked. You see here that the speed training in the green relative to the other three conditions, speed training significantly improves speed. The reasoning training in the yellow improved reasoning relative to the other three conditions. And memory, it was still better than the other three conditions, but it was non-significant at the 10 years. So each of the programs, as hypothesized, showed these very long-term effects. And we had shown these effects up through 5 years and showed that they lasted through 10 years. And at the 3-year mark, where we gave the booster session, the booster effects were evident for all three interventions at the 3-year mark. So again, the booster training was very important. We also showed that, and for really almost the first time this was shown, that this type of training would generalize to these functional measures. And here you see instrumental activities of daily living. Participants in the 3 intervention conditions relative to the control condition reported less difficulty carrying out their daily task at 10 years. So we were very excited about that finding, that the training not only improved the cognitive measures, but it also generalized to these everyday functional measures. Now, as I mentioned, we did a 20-year follow-up. We received funding from the National Institute on Aging, and we, as part of that follow-up, analyzed Medicare records, and we matched participants, in this case, over 2,000 participants from the original sample to their Medicare records. We excluded people without a match or excluded Medicare Advantage members. They tended to be healthier, and that's through private insurance. And so there weren't as complete records, particularly with regard to dementia diagnosis. We used a well-established, what's called the Chronic Conditions Warehouse, Alzheimer's and Dementia Diagnosis algorithm for the Medicare data. And this was based on International Classification of Diseases code, ICD codes, which is an algorithm for diagnosed Alzheimer's and related dementia, or the acronym is ADRD. And this is not a, we did not have access to adjudicated dementia diagnosis through the Medicare records, but these ICD code algorithms that we used are known to show close agreement with more traditional neurological workups for dementia. So we were pretty confident in terms of the dementia diagnosis. And we also noted that the resulting groups were very well matched in terms of different baseline demographic and dementia risk measures, including we looked at cardiovascular risk factors, blood pressure, cholesteremia, and other cardiovascular risk factors, and these groups at baseline were very well matched on those measures. As I mentioned earlier, the paper reporting the results of the active study after 20 years came out about 4 months ago, early February, in Alzheimer's and Dementia, Translational Research and Clinical Interventions. Dr. Marilyn Albert was the corresponding author for this research paper. Norma Coe was the lead author of the paper, and here you see the other authors from the active group on that paper. I included here at the bottom a quote from Richard Hodes, who's the director of the NIA, who said that the findings here suggest that moderate cognitive training could delay the onset of dementia over subsequent years. There's still more research to be done about how this works, but very promising lead to move the field further into developing effective interventions to delay, prevent dementia onset. Here are the main results of the 20-year outcome paper. And the speed of processing training with boosters uniquely reduced the risk of onset of dementia based on the Medicare records. And if you see here the speed in the purple bars, it was the speed with booster that showed the lowest incidence of dementia over the subsequent 20 years. 39.8% versus higher percentages in all the other conditions, particularly compared to the control condition at 48.7%. So compared to the control, the speed plus booster versus the control showed a 25% risk reduction over those 20 years. And even comparing within the speed condition, those who were randomized to receive the boosters versus those who were eligible to receive the booster but weren't randomized, there was a 19% risk reduction. That those with boosters did better in terms of dementia risk than those who did not receive the booster, who had just gone through the initial training. If you see here the memory training and the reasoning training, there weren't any differences between having the booster or with or without the booster in those conditions. But again, it's the speed training with booster that really made the difference. So it certainly raises the question of why does speed training do this? We think one of the reasons is that it required what's called procedural learning or implicit learning. And this is learning that is more like acquiring an unconscious skill or habit, sort of like learning to ride a bike or learning to tie your shoelaces. You're not necessarily conscious of acquiring that skill, but nevertheless, through repeating the procedure, you pick up the skill. In contrast, memory and reasoning require more explicit learning, more like learning facts and strategies versus more implicit kinds of learning. Another important factor we think was that speed training was adaptive, so that the participants in that condition started at different levels of difficulty given their different abilities. So those who had showed slower speed of processing at the beginning moved through the exercises more slowly. Those who were faster at the beginning proceeded to more challenging tasks more quickly. And then it proceeded at their own pace throughout the training. That was not the case with either the memory or the reasoning intervention. Those were not adaptive interventions. And this was easier to do on a computer than it was to do in a group setting, led by a facilitator. So the speed training was adaptive. And thirdly, we think that the speed training is very effective at driving brain plasticity. And there are extensive animal model data to show that speed training is particularly effective at driving functional, structural, and cellular brain changes. And so we know that speed training works differently in terms of brain level changes than do the other interventions. And so speed training seems to be particularly adept at driving those changes. And as I mentioned, we have research from the animal literature suggesting that speed training drives brain plasticity in rodents. So using different operant conditioning procedures and discrimination learning tasks that are speeded, that the speed training shows different brain level changes in terms of brain speed and accuracy and overall brain health in those who go through this kind of training. And we see the same thing in people, that speed training tends to drive brain plasticity in people, and it relates to better brain activation through where we measure this through task-related functional MRI imaging that measures the activation of the brain during different tasks like executive function task. Better brain integrity through measures like diffusion tensor imaging or DTI, where we're measuring white matter integrity, track integrity. We have studies on better brain connectivity that during resting state, functional connectivity is increased through speed training and different regions of the brain. Neurons in different regions are more connected, and you have whole populations of neurons that are firing together. And better brain modulations in terms of upregulating neuromodulators. There was a very important study that came out last fall showing that speed training, similar to what we did in active, upregulated acetylcholine and dopaminergic functioning, and increased acetylcholine levels, and that may be one of the mechanisms underlying the effects. Now, there are many open scientific questions. How does speed training reduce the risk of Alzheimer's disease and related dementias? Is it through reducing the different biomarkers of disease like amyloid and tau, the neuropathological proteins? Does it increase brain reserve by increasing functional connectivity or increase myelinization? Does it improve neuromodulatory functioning, like we just mentioned, acetylcholine? Does it strengthen the blood-brain barrier? Perhaps it builds reserve by changing real-world behaviors, so it makes it more easy for people to interact socially, to engage with their world, perhaps improve sleep. As I mentioned, the training we gave was fairly modest training, 10 to 22 and a half hours of training over a period of about 9 weeks, spread over about 3 years. What if people did these booster exercises every day for a year? What if they train like we often train when we're doing physical exercise? So repeated training over time. What benefits might be conferred with that kind of training? We don't know. The additional training seems to be important, as I mentioned, with the boosted training, and we'd be interested in knowing whether the training selectively affects the transition from normal aging to mild cognitive impairment, or from mild cognitive impairment to dementia, and whether there are other effects on measures of health, Medicare expenditures, movement into long-term care facilities, diagnosis of mental disorders, mortality. Lots of other questions to be examined here. And then there's the broader impact of active, implications in terms of public education, public health education, implications for clinical guidelines for medical associations, implications perhaps for Medicare coverage of digital health programs like speed training, implications for Medicare costs. There may be tremendous savings if we can reduce dementia risk by this amount or more at a population level. And then implications for Congress and the taxpayers as they think about the value of NIH spending on basic research like this. I wanted to just point out here this study called the U.S. Pointer Study that involved speed training exercises similar to what we did in active. This is a multi-component study. The results just came out about a year ago. It's part of a more comprehensive lifestyle management program where participants followed either a more self-guided type of program or a structured lifestyle program over a 2-year period. Both focused on the same lifestyle domains, but they differed in how structured they were, and the more structured programs seemed to confer more benefit. We don't know if it reduced Alzheimer's disease or other dementias. They haven't looked at that question yet, but it did seem to afford some cognitive protection. And it could be that these cognitive exercises like speed training make these other components more effective. We just don't know, but I think this is, you're going to see more and more of these kind of cognitive training exercises built into these multi-component programs. This was started by the Alzheimer's Association. It was predicated on a study called the Finger Study in Finland, where it involved multiple risk factors, and showing that over 40% of dementias may be preventable through modification of these risk factors. So with that, I'd like to end, and thank you very much. Here's my contact information. I'd be happy to answer by email any questions you have, and of course, right now, answer questions during the Q&A. I want to thank you for your attention.
Thank you, Dr. Rebok. That was an insightful, elucidating, and insightful presentation that provides hope for people seeking to lower their risks for dementia. Before I ask you a few questions, I'd like to take a moment and ask the audience to drop any questions that they may have in the Q&A. Dr. Rebok, your excellent talk brought us to a few intriguing questions to mind. You did quite a bit about talked about speed training, but why did speed training with boosters show a benefit on the development of dementia while memory and reasoning training did not?
That's a question that a lot of scientists are interested in at the moment. I think one possibility has to do with this adaptive nature of the training. That speed training was computerized and adaptive, so it allowed people to start at sort of their own level of ability and progress through the training at their own pace. And as part of that, they received lots of feedback about how well they were doing, and they could go through the program at their own pace. The other two interventions, memory or speed, were not adaptive. So everybody received the same strategies. Everybody went through the program at their own pace. The other, I think, major factor is the nature of the speed training. It involved what we call implicit learning or procedural learning, which is more like learning an unconscious skill or habit. And the reasoning training and the memory training, they involve more what we call explicit learning, where you explicitly had to learn different facts or different strategies. And it may just be harder to pick those up, particularly given the modest amount of training. Maybe with additional training, we might have seen effects for those two interventions, but we did not, in this particular follow-up at 20 years, we did not see effects for those two interventions. We think a lot of it has to do with the adaptivity and also with the nature of the learning involved.
Okay, thank you very much for that. What about other cognitive stimulating activities such as brain crossword puzzles and some of the brain teasers that they have out there?
Yeah, well, that's a question we get asked a lot. And I think that, crossword puzzles and other, mental exercises like, or puzzles like Sudoku and Wordle and other puzzles like that, they're certainly a great thing to do in the afternoon. They're enjoyable activities. I enjoy them myself. My wife does a lot of crossword puzzles. We often do them together. But as far as I know, there are no rigorous randomized controlled trials that have shown that crossword puzzles can reduce the risk of dementia. And in fact, in a lot of randomized trials, crossword puzzles are used as a control condition. So you want to sort of control the amount of cognitive stimulation, but you don't want to include something that's going to change cognition too much, relative to whatever intervention you're testing. So I think that, there are observational studies there or correlational studies out there that show a relationship between doing cognitively stimulating activities like crossword puzzles and reduced risk of dementia. But in those studies, it's been very hard to untangle sort of cause-effect relationships. So it could be that people who are already very cognitively able, who are not suffering any symptoms of dementia, are the ones most likely to engage in those activities. So it's hard to say whether it's the activities themselves that are reducing risk or it's the fact that people who are already able are engaging in those activities. So it's that sort of cause-effect relationship that's hard to tease out.
Very much for that response. And thank you for responding to our questions with such neat insight. Let's see what questions our friends might have put into the Q&A for you. Corinne, are there any additional questions in the Q&A?
Yeah, there's a handful of questions coming in, and they're all great. Dr. Rebok, we have a lot of questions about getting access to speed training protocol associated with the active study. It sounds like there's a lot of interest in people wanting to try to figure out what they can do at home, in their own time to impact their brain health and dementia risk.
Yes, so the active speed training was based on a program that was developed by Carleen Ball and Dan Renker. And it involves something called the useful field of view. So training people to take in a lot of information at a single glance while paying attention to a central target, trying to ignore what's out there on the periphery. And that type of training seemed to be very effective, not only improving speed of processing, but also generalizing to a lot of everyday activities like driving behaviors and driving safety. Their program was eventually acquired by a company called Posit Science, and it was further developed under the label of Brain HQ. And there is a particular program in the Brain HQ suite of programs called Double Decision that probably most closely mimics what was actually used in the active study. The app for those programs in Brain HQ is downloadable either through Apple or Google Play. And it's a program that again was most similar to the speed training used in active. However, I must say that when you're searching for a cognitive training program that you want to incorporate into a brain health routine, you want to try to pick one that really fits your lifestyle and your motivation and your habits. It doesn't do any good to, acquire a cognitive training program and then not use it. It's not going to be very effective. And it's also important that, there are dozens, hundreds of these cognitive training programs out there. I would suggest that, particularly given the results of the active trial, that you look for one that involves visual processing and divided attention or dual attention. Those are the types of that's the type of training that seems to be most effective. I would also do a little research on the product itself. What evidence backs it up? Is there independent evidence? Is it just the developers of the product that are saying it works? So you want to be an informed consumer of these products. And I would also urge everybody to build this, figure out a way to build this into your everyday life. So that's sort of a seamless part of your daily life. Build it into a routine where you're going to use these products, these training programs. And I think being realistic in the expectations of how quickly you're going to improve, I think is very important. And these programs do take effort. They do take a investment of cognitive effort. It's not like you can just do these one or two times. Like I like to say to people, these programs are not cognitive vaccines. It's not like you take the program one or two doses and then it prevents you from ever declining cognitively or developing dementia. So I think you really need to find one that fits your lifestyle and build it into a healthy lifestyle. And don't do them 24/7 either. I think people can go overboard the other way if you find something that works and then you start to neglect social relationships, exercise, good nutrition, things like that. So there are opportunity costs to doing too much training. So
Sure.
you have to come up with a good training schedule.
Yeah, it sounds like you're really emphasizing a balance of lots of different things we can do
Exactly.
to reduce our
Exactly.
risk.
Yeah.
Yeah. There's two questions related to that are a little bit more sciencey in terms of when you were looking at these results, did you look at either what other types of things did you account for when looking at the effects of speed training? So the specific questions about medications or dosages or cognitive status. Well, I guess we know the outcome there, but medications or those types of things, as did you control for those types of things then, and also whether you looked at family history of the participants at all to see you know what type of family history people had in terms of dementia in their families, and maybe how that influenced any motivation to do the training, that sort of thing.
Yeah, thank you for that question. We had very limited information on family history. I wished we had more. That was not a central part of the analyses. We did have a whole set of what we call covariates that we controlled for in these analyses, things like age, sex, race, years of education, marital status. Um, we also controlled for baseline health factors. So as I mentioned, different vascular risk conditions, hypertension, diabetes, congestive heart failure, things like that. We control for smoking behavior. So there are a variety of different variables we controlled for. And as I mentioned, these groups were very, very well matched at baseline. So
Mhm.
we controlled for as much as we were able to control for in these analyses.
Yeah, yeah. Um, do we have any information about post-intervention activity in these different groups? What might they have changed in their everyday life following the training that might have kind of influenced these findings?
Yeah, I really wished we had better information about that. When we published the 10-year results, we got that question a lot about, well, what were people doing in the interim? They hadn't been seen for many, many years. Do you have any information about, were they using these strategies that were taught during the classes? Did they change their lifestyle in any way? Very limited information, although we do have lots of anecdotal reports. So we have people, there was one person who was in the speed training who said that, and she was at the Penn State site, and she said she was felt much more confident in driving through the mountain roads and getting to different places. And so her life space really kind of increased as a
Mhm.
result of having this training. And there was another person in one of the memory training groups who said that following the active training, she went out and enrolled in some community college courses because she felt so much more confident in her memory. And so
Mhm.
without the training, she never would have done that.
Yeah.
And so we have lots of reports like that. And we think people are, continue to use these strategies. Uh, in fact, that was built into the training. And that, I think, made active very different than what's typically done in cognitive training or what we sometimes call brain training, where we really try to emphasize a connection between the strategies that people were learning in their everyday lives and how they could apply what they learned and take it outside the classroom and apply it. So that was really built into the training, received a lot of emphasis, and we think that's why we saw some of the generalization that we did to the everyday activities.
Yeah, very cool. So we know that Alzheimer's is one type of dementia, and there's different types of dementia due to different underlying brain conditions. Do you think there are different cognitive training effects on different types of dementia, or is it a more general effect? I know you don't have the answer per se, but just kind of if you were to hypothesize or
Yeah, well, I mean, when we looked at these Medicare records, they grouped the dementias into one single category. So we, couldn't look at separate, Alzheimer's disease, vascular dementia, frontotemporal dementia. Everything is grouped into Alzheimer's disease and related dementia, ADRD. There's a separate category for Parkinson's disease. We haven't looked at those data yet at all. Uh, but I think that it may be more of a generalizable kind of effect that it cuts across dementias, but I think it's an open scientific question. I really, and in particular type of dementia may be better served by a particular type of intervention. We just don't know sort of what the optimal sort of match is in terms of intervention and outcome.
yeah, certainly sounds like an important next step.
Yeah.
Sorry, I didn't mean to cut you off there.
No, that's okay. And I think, doing much more cross training too might be not just like speed training, but speed plus memory training or speed plus reasoning training. Maybe different combinations work better for certain types of dementias.
Sure, yeah. There's also, when we think about brain health and things we can do, we hear a lot and say a lot to learn new things, learn a new language or learn, take on a new musical instrument. Um, how would this relate to speed training? And, do you think you'd see similar effects of this type of learning compared to speed training or?
Yeah, I mean there is a lot of observational evidence about the effects of these cognitively stimulating activities, learning a musical instrument, and in fact there are controlled clinical trials suggesting, that's efficacious in terms of improving cognition. Um, I don't think it has to be an either or. I think you could do these activities in conjunction with speed training. It might make it easier to do some of these activities or you acquire them more quickly. So it shouldn't necessarily be thought of, I do this or that. But again, kind of go back to the argument about, pick something that you're going to stay with. Sustainability is such an important part of this. And, a lot of times, people adopt these cognitive training programs or adopt some stimulating activity that is, they don't continue it. It's like signing up for the gym in January and then by, February or March, you're no longer going to the gym.
Mm-hmm.
And I think it has to be an activity that has some meaning to you. I think, a lot of times people engage in what I like to call hobby learning. It may be an enjoyable activity, but it doesn't really challenge you in any way. It doesn't sort of stretch those mental muscles. And I think doing something that, even if you're like doing crossword puzzles, don't you continue to do just the same level all the time, increase the level of difficulty and challenge and keep it as novel as you can so that you don't, get bored with it and you don't sort of just top out.
Yeah. All right. I have one more comment before I turn it back over to Tony, and this is just to share some of the kind remarks that are in the Q&A box. So thank you for such a great and interesting talk, Dr. Rebok, and thank you for the engaging talk and dedicating your career to this important work. So with that, I think that's a lovely way to turn this back over to Tony.
My pleasure. Thank you so much.
Thanks again to Dr. Rebok. We are so lucky to have you join us tonight. Now let me pull up the PowerPoint for you. Okay, can folks see the...
Yes, sir.
Okay. So you will receive an email with the key takeaways and a link to the recording in about a month. Our next webinar will be in the fall or the winter of this year. And if you would like to hear about something in particular, please send us your ideas for topics. You can email me directly. That's absolutely fine. Would love to hear from you and get your insights into what works, what doesn't work about these, where you see areas for improvement, and especially what you want to hear about next. You may be interested to know that the Baltimore Walk to End Alzheimer's is on Saturday, October 24th. Please join us if you can. The Alzheimer's Association has a wide variety of programming for people living with dementia and their caregivers. They also have a new app, so you might want to check out their website and look for more information there about some apps that might be helpful. Most notably, the Alzheimer's Association has a 24/7 helpline. That number is 800-272-3900. Please contact them if and when you need resources or support. If you're in the greater Baltimore area, you may be interested to know that Johns Hopkins Alzheimer's Disease Research Center has a number of studies that are currently enrolling volunteers. Those with or without memory difficulties may be eligible. For more information, call 410-550-2281 or visit alzresearch.org on the web. Did you know that the AARP has a Brain Health Resource Center? It gives you a nice variety of tips, tools, and explainers on brain health, including a new Staying Sharp tool. This page was just developed by AARP's Global Council on Brain Health. Check it out. We owe a debt of gratitude to the following individuals who contribute to BrainMatters programming year-round. They're all volunteers in this collaborative space, and they help identify the topics and the dynamic speakers on brain health. Most importantly, we thank you for joining us. Your brain matters. Thanks for being here tonight.